Make sure it's recording.
Hi, everybody, and welcome to this month's Rutgers NJ Health Prep webinar. This month's topic is preventing inpatient violence using 3 steps of safety, and we're going to be joined by Dr. Tom Bartholomew as our presenter. He is with Rutgers Institute for Inpatient Psychiatric Rehabilitation, along with Jennifer Sperduto, my trusty colleague here, and myself. So we're so glad to have you with us. And this presentation is sponsored by the New Jersey Department of Health, Division of Behavioral Health Services, and Rutgers State Hospital Psychiatric Rehabilitation Initiative. So welcome. This is an interactive training, and we encourage you to ask questions and participate throughout the session. And just as with every other month, a recording of this webinar will be available after the presentation at the Rutgers SHPRI website that is listed on the screen. And Jennifer will also, or I will, drop some links into the chat so that you can navigate to them. Couple disclaimers to read. The Psychiatric Rehabilitation Educational Program, or PrEP, is an online forum for a variety of topics relevant to the state psychiatric hospital staff. While Rutgers and DBHS are co-sponsors of this program, the PrEP webinars are peer-presented, and as such, content is independently developed by the presenter each month. The views and opinions expressed in this program are those of the speakers and do not necessarily reflect the views or positions of any entities they represent. Also, we'd like to note that this webinar is being recorded for later viewing, and so just please be mindful that anything and everything that can be said will be recorded and live in perpetuity. So it is my great honor, great because he is my supervisor, and this is my opportunity to let him know how grateful we are to have him as our supervisor. Today's presenter is Dr. Tom Bartholomew, and he wrote this bio. So as you can see, he believes that he has broad shoulders and a winning smile. And again, yes, he wrote this bio, but of course we believe that. He's been working in the field of psychiatric rehabilitation since 1988 and has worked in residential and clubhouse programs and was the director of a partial care program before entering academia. For the last 20 years, he has been on the faculty of Rutgers University and a consultant to the New Jersey State Psychiatric Hospitals. His current research initiatives include implementation theory and restorative clinical supervision. Tom is an avid ultra runner and metal fabricator in his spare time and lives in rural Flemington, New Jersey with his wife and 2 kids.
That guy sounds fantastic.
He is amazing. Tom, would you like me to read the learning objectives, or would you like to read them?
You go.
I can. Okay. So let's just orient ourselves to the learning objectives, what we hope you'll be able to take away by the end of this presentation. We'd like you to be able to identify at least one theory or type of inpatient violence, understand the acronym VEP and 3 steps to safety, and correctly identify VEP, which you'll learn what that means shortly, in a video. Next slide, please.
All right, I'm going to take over from here because I want you all to try to either grab your phone and you can scan this QR code. You can go to the link that Dawn's going to drop in the chat box, and we're going to do an activity to start our discussion about inpatient violence. So grab your phone, scan the code, and enter a word, a phrase, multiple words on what you think causes inpatient violence. What are the causes of inpatient violence from your perspective? So it's either this code or the QR code, or you can go to menti.com and enter this the numeric code at the bottom. So as you start responding, words that are duplicated and come up multiple times will become bigger. And so we're going to let this run for a minute and enter. I think you can enter up to 6 different words, and then hit submit. And you can see, as the word cloud grows, the different responses that come in on what the attendees of this webinar think are the causes of inpatient violence. So I'm going to let that run and turn that back to you, Dawn.
Wow, it's pretty awesome actually to see it grow.
Isn't it neat as it populates? So while we're letting folks, have a minute or two to, enter in their thoughts, and again, remember, you can input more than one potential cause. I want to ask you, Tom, what are some of the little known issues in the study of inpatient violence?
Right. Yeah, thanks. And I appreciate the fake questions that we agreed upon ahead of time. They're terrific.
Because you're going to agree to do this for my dissertation defense as well.
So, I mean, this question for me really cuts to the heart of what I want to talk about today, which is the idea of what do people think causes inpatient violence. And judging from the word cloud, I think people are pretty much in line with what I'm going to be talking about. And also what is actually controllable by staff. There's certainly elements about inpatient violence that we're never going to be able to control, probably. So I just want to let this thing percolate. So it seems like anger, frustration, fear, miscommunication, and psychosis are the big. So the larger the word, the higher the frequency. So that's how you can think about it.
Does that seem to kind of follow in line with the research out there? That
it does. And take me to the next slide, if you would, Jen. And yeah, okay. So some of the things that I've learned about inpatient violence, and I did this for my dissertation, so I had to read more than any person should ever have to read anything. The first thing was just how common inpatient violence is. And here you can see, this is certainly old, 1995, but the chance of the average psychiatric facility staff being assaulted is about 1 in 3. So if you're sitting in a room of 3 people, good chance one of you has been or will be the victim of violence. Secondly, compared to other industries, the risk of injury in a public mental health hospital is greater than the injury rates in agriculture, mining, manufacturing, transportation, and construction combined. I actually underline that. And I've looked this up numerous times because every time I present it, I can't imagine it's true, but it's an extremely important issue. The other thing to note about this are the consequences for everyone involved with inpatient violence, including patients. One of the things you tend to see is the relationship of violence to burnout. And what I've learned, there's been 2 large studies, one in Europe, another in Scandinavia, about the bidirectionality of burnout. So in other words, people burn out when they're exposed to violence because of the stress. But people that are experiencing burnout experience more violence as well, which I did not anticipate. I never thought about it. And you can imagine why somebody that's burnout is often unavailable emotionally to the people around them because they're suffering and because of their experience of the stress in their life. Some of the other things you see are staff turnover and just the basic trauma that people experience. One thing to note about these numbers is that, for the most part, violence is not serious. And so even though the frequency is very high and is unacceptable, it's very often slaps and whatnot. One other thing to note is that verbal violence is often not even recorded and constitutes a whole other level of exposure for staff. Next slide, please. The other thing I've learned was an article by Whitehead, and all of these, everything I reference will be available in the slide deck, which will be sent to you. But this article talked about what's called a heavy tail distribution. And if you see on the left, The y-axis is the straight up and down axis, and the x-axis is the horizontal one at the bottom. And if you put the number of patients on the y-axis and the number of violent events on the x-axis, you see that the tail of the distribution goes way out, meaning that very few patients are responsible for a very large amount of violence. And I replicated the Whitehead study at a hospital in New Jersey, and you can see that to the right. And this is actually restraints. So you see the same heavy tail in restraints that you see with violence. I did it also with violence, and you see the same pattern. And I suspect that this pattern exists all over the country and internationally. One of the reasons this is so important is if you're not careful and you're studying violence prevention programs, the addition or subtraction of one patient might lead you to believe that the program is effective or not effective, because that person is bringing with them so much of the dependent variable. So much of the violence is associated with that one person. So it's an important thing. I'm not sure if everybody's ever heard of this before. Next slide. I should say with the heavy tail distribution, there are ways to control for that. So there's what's called a within subject design, where you compare Joe to Joe, and so you can deal with it, but you have to know about it in order to deal with it. So this slide refers to something you see in the literature, and it's a distinction between mad and bad. And it's not PC anymore to say this, but when the literature is referring to mad as ill, mad, crazy, ill, that kind of thing, and bad being a bad person, like they're doing this and they're a bad person. I added another mad to mean angry, which is something we'll talk about as we go forward. But it's very common for literature to identify patient characteristics associated with inpatient violence, and of course it's younger male. Diagnosis is often paranoid schizophrenia, things of that nature, or personality disorders. The number one, by far, predictor of violence is a history of violence. And so as much as hospitals are criticized for having violence in them, we have to remember that people are put in the hospital or end up in the hospital because they've been violent oftentimes. So it's not that the hospital is causing the violence necessarily. And then, of course, illness severity, which was noted in the word cloud, right? That the more ill someone is, it can be related to violence. Next slide, please. So the other kind of odd thing I found in the literature comes from this woman, Crowner, who wrote a textbook on inpatient violence. And she refers to a study that she did where she videotaped psychiatric units and compared what she saw in the videotape to incident reports of violence. And what she noted was that the number of what are arguably violent events and particularly verbal aggression was way higher than what was reported in the incident reports. And I think people understand this, which is if you reported everything, you might just spend your whole career just doing incident reports, right? If it exists at that level. Okay, so that's another important notion, is this idea of just the sheer number of violent events that are probably happening. So one of the things I think that this lends itself to is the research on training to prevent violence. And we did this at one of the hospitals in New Jersey, where there was a therapeutic options has a violence prevention component. And we looked at violence before and after, incident reports of violence before the training and after the training. And we found that violence went up after the training. And it could be this Crowner effect, right? It could be that people are just more sensitive to the violence is already occurring and they just report it. But it's not that training someone in violence prevention causes.
More tuned in.
Correct. Yeah. Next slide, please.
So what do you think the role of mental illness is in the cause of inpatient violence?
That's a great question. I'm glad you asked that. Yeah, it does make sense to assume that if somebody's in the psychiatric hospital and they're diagnosed with a mental illness, that would be could be the cause of violence. There's this interesting term, diagnostic overshadowing, that refers to the maybe mistaken conclusion that if somebody has schizophrenia and they're violent, that they're violent because they have schizophrenia. There's actually compelling evidence that people are violent in state psychiatric hospitals, often for the same reason they're violent in any situation. And the word cloud referred to some of that, where they can feel disrespected, or, they can feel provoked, all of that. This is actually a picture of my cat. And what's really interesting about this picture is right after I took it, my cat turned around and said to me, "I'm Batman." I just wanted to do that. It's whole presentation. I was just waiting to do that. All right, let me just check here. So just the last point about diagnostic overshadowing, the reason this is so critically important, and the reason it matters what staff think are the reasons for violence, is when staff attribute violence to patients and they externalize the belief that violence happens not based on whatever they do, but it's the patient doing it, it can reduce their the belief in the role they have in violence, the maybe subtle contributions that staff might bring to violence. Next slide. Next slide. So this idea of that violence is not so simply understood as a characteristic of patients, and particularly of patients' mental illness, was really driven home by this fellow, Len Bowers. And Len Bowers was, before his retirement, was the premier researcher in inpatient violence internationally. He's out of England. And he developed the safe wards model. And this model was an evolution from a simpler model called the city model, where he predicted that three things would identify violence, one of which was a positive appreciation of patients, structure of the unit, and I forget the third one. But that model did well in one study, one randomized controlled study, and then failed to predict in the next two studies. And he concluded that maybe there are other drivers. So he did a literature review with his team of 1,000 articles on inpatient violence, if you can imagine that. And they drew out of those 1,000 articles these 6 potential drivers of inpatient violence. And you see patient characteristics are there, stuff that the staff does, rules and regulations like that, you can't get out of the hospital, you can't go home, or things like that. Getting a call from your family and the family says, we wish you were never born, or you're not going to move home with us, or those kind of things. So if you really want to understand the field of inpatient violence, the article they wrote on that large review is worth reading because it's just so comprehensive. The one criticism I have of the safe wards model is it doesn't attempt to rank order these domains. And while I think they all are contributors, I suspect that if we were to rank order them, you would be able to do that, and you would see that that some things are probably more explanatory than others. The other thing is it's not always clear what you can do about these. What do we have control over? And I'm going to argue that the staff team, the staff intervention, is an area where we can exert some control, and maybe more control than in some other areas. Next slide, please. So this fellow, Henk Najimen from Norway, put out an early model of inpatient violence, which I think about all the time. And it's the idea that, like this thermometer, everyone has a boiling over point, a point at which they're just going to lose it. And and justifiably so in many cases. And it's consistent with the safe words model, meaning there's many things that can increase the temperature for a person, you might say, including what he terms communication stress. So stress in which staff are making activity demands, or they're denying requests, or they're limit setting, all of which Najiman thought were contributing to the chance of boiling over. The other thing important about this idea is, and we know these people, right? Some people are right by the boiling over point all the time. And it really takes almost nothing to push them over, or very little. So what I'm going to talk about in the next, in the time we have left, is how do we reduce certain contributions to that boiling over? In other words, we can't address age and gender and diagnosis and stuff like that. But there are some things we can control, and if we remove them from the heat, from the thing that's driving this temperature up, that's the idea, that we can prevent violence by doing that. Next slide. So here's another study that my team and I replicated in New Jersey, and it came out of England. It was done by Joy Duxbury. And what she did was she compared the perspectives of staff and patients about what causes inpatient violence. And these word clouds are the, on the left-hand side are what we call in New Jersey direct care staff, or their nursing assistants. So these are folks that run the units, and they don't get a lot of training from the system, and they're actually most exposed to violence. That most violence, I believe, in New Jersey and probably elsewhere in the country occurs on units. To the right are clinical staff. These are psychologists, rehabilitation workers, and social workers primarily, and I believe nurses are there. So Duxbury, in her study, she found that, and this is kind of what I'm going to be. Why don't we go to the next slide? So if you notice on those two, the direct care staff and clinical staff are saying patients are the cause. This word cloud is a word cloud from patients, and from the patient perspective, they're saying it's really staff are the cause of violence. And in Duxbury's case, they actually went on, they put observers on the units, and the observers often agreed with the patients in the sense that the staff didn't recognize that some of the demands on patients and the communication with patients seemed to patients to be provocative, but didn't seem provocative to staff. They seemed like reasonable behaviors to staff. This is not to say that staff are intentionally provoking patients. It's just to say that there can be a communication stress that's more visible and the patients are more aware of than maybe the staff are. So some of the quotes from, say, direct care staff about what caused violence, they said that inconsistent use of policies, noise, and high census were drivers of violence. And they said good communication between staff and patients reduced violence. Clinical staff said the drivers of violence were increase in forensic patients, and they used the term criminogenic contribution, an increase in patients with substance abuse disorder, increase in patients with personality disorders. Other drivers were that the direct care staff, that other group, didn't get sufficient training or support, and that was a contributor. And lastly, the clinical staff said there were poor clinical interventions that didn't meet patient needs, and that was thought to be a contribution. Patients said poor treatment was a cause of violence, poor staff communication, overcrowding. And they thought what prevented violence was an increase in staff fairness, a positive attitude by staff, and respect towards patients were the primary protectors Okay, next slide, please. So I know this is a lot, and this is part of my plan, just to overwhelm you, but to really try to unpack some of the literature on inpatient violence. This is the hopefully one of the last nerd-like things I'll talk about. But this is my dissertation, and this is called a path analysis. And what I was interested in were the attributions of staff about the causes of violence. And if you can think about an attribution in this way, imagine you see me in the parking lot and I'm stumbling around and I appear intoxicated, and you may think to yourself, oh, what an idiot, or you may laugh at me, or you may just ignore me, or you may be concerned that I'm going to get in my car and drive, that kind of thing. Now imagine the same situation, but instead of being drunk, that you attribute my behavior to me having a stroke and a medical problem. And that attribution might actually lead to you running over and offering me assistance and having a completely different behavioral response. So this path analysis, if you look to the left and you see responsible, not responsible, what I tested was if the staff believed that patients were responsible for violence. In other words, they believed in an external explanation for violence. They weren't provoked. Staff had little contribution to what was happening, but it's really the patient's choice. They're doing it on purpose. You see the arrow go up to anger and lead down to the value of coercion. So staff that believe that patients are doing this on purpose, in essence, believe coercion is a good response. So that could be seclusion, restraint, PRN medication, or just laying down rules. We're going to shut this down. By contrast, if staff have a different attribution and believe that either the patient is being provoked or is the subject of procedural injustice, where they're not being treated right, or that they're very ill, or they have a emotional dysregulation caused by a personality disorder, it can lead to sympathy. And if you follow that path on the bottom, you see an increase in a willingness to offer help and engage in help-giving behaviors. And then you see those numbers, 0.53 is the relationship between sympathy and help-giving, or between anger and the value of coercion. Next slide, please. The other finding in my dissertation was that and this makes sense, right? But the relationship between help-giving and the value of coercion is a negative correlation. And the danger of this, of course, is if you believe that it's the patient's responsibility is violence and you have little or no responsibility or part in it, you may not engage in certain behaviors that could be really helpful, which is 3 steps to safety, and that's kind of where we're headed. I will tell you a statistics joke my wife told me yesterday. She said, everyone who confuses correlation with causality eventually dies. I should drop the mic on that one, because that's
yeah.
Oh, that was good. So good. So good.
So I do have one question for you.
Yep.
Well, no, I actually have exactly 4 questions, but we're on the 3 of 4. What are some of the practical takeaways from your all of this research? And by the way, you're at 30 minutes. I just
okay. Thank you for that. Okay. Next slide, please. Yeah, so that's a really good point. All of my blathering is intended to lead towards what can we do and what's the argument for doing what we do. Here's a study I did a while back, and I looked at 30 articles that identified controlling and authoritarian behaviors on the part of staff as being associated with patient violence. And it's consistent with this idea that staff can have a role in violence. It's not 100%. It's not nobody's necessarily intentionally provoking anyone. But so challenging this and seeing how we can change controlling and authoritarian behaviors. And you can see the other things in the articles that were the drivers there as well. Next slide, please. So the last piece of, or one of the last pieces of unpacking violence is this idea of trying to find a taxonomy or an organizational system by which we can understand where violence is coming from in an inpatient setting. And this was a study done by Kwan back in Australia, and he identified 3 types of violence. The first being instrumental, which is organized, could be revenge or predatory. And he found that this was more common in jails and prisons, and also in forensic facilities, where people might find it advantageous to engage in certain violent behaviors because it can protect them and establish their status. The second type is psychotic, which is, and we see this, anybody who's worked in this setting see this as a delusional belief or fear of harm. So a person might think you're poisoning them or you're threatening them. And you can see, again, for forensic settings and civil settings. And then his research, and this was replicated by a fellow named Dean Marth in the United States, he found that the third type of violence, called reactive violence, is impulsive or angry reactions to events. So this is a patient that's reacting to an authoritarian staff person could be experiencing administrative malfeasance. That's awesome. This could be reacting to or engaging in reactive violence. And you see the numbers there, forensic and civil, where in civil hospitals, it's potentially very large number are reactive violence. Next slide, please.
So I have a question.
Okay.
So with all of this information that we know, and that we know that reactive violence seems to be the greatest proportion of inpatient violence, can you tell us about the approach that you developed?
Yes, absolutely. So you mean get on with it, basically. Okay.
Get on with it, yeah.
Okay. So the strategy I used, I learned from this fellow, Dr. Vikram Patel. I learned later that he's a Harvard professor. And next slide, please. He presented a TED lecture, which I would highly encourage you to watch that if you're interested in this topic. But he identified this thing he called task shifting. He later changed it to task sharing. And he coined the acronym SUNDAR. And it's an approach to try to simplify complex situations so that we could shift a response to those situations to people with less and less training. So paramedics are a great example of this. You don't need an MD to be a paramedic, but you do need to know a good deal about emergency response. So SUNDAR stands for simplify the message, which we're going to attempt to do, unpack complex interventions. And I was unpacking for the first half of this training, and I apologize if it was too complicated, but that's what it was. 3, deliver it where it's needed. So we need to deliver this on the units, the violence prevention on the units. Make it affordable. We'll see about that. And then what do we do with the professionals? We reallocate them to building more capacity and to supervision. Next slide, please. Next slide, please.
Sorry, I was trying to get my camera on. Tom, before we move on, there was a question that came in the chat about a continuum of anger. Basically, if the person could stay in the spoken continuum, it was less likely that they would respond aggressively. If they moved to aggression towards property, animals, there was a greater likelihood that they would become aggressive towards people. Have you seen anything like that diagram or something similar?
I have not, but it does sound like one of my mentors is Eugene Colvin, he's now the director of the medical security officer program at Ancora. And he talks about that elevation of arousal and what are the strategies for each level. But I think that makes a lot of sense just from what I know about brain science, that you want to keep people in the prefrontal, ability to think and talk. Yeah, but that's really interesting. Yeah, but I don't know much about it. So here are some common Sundar interventions. Concussion assessment is a good example, right? Where you do it on the football field. You don't need to take them to the hospital, at least not for the first step. Stop, drop, and roll, sugar testing. So these are consistent with the Sundar acronym of unpacking. I think CPR is maybe one of the best examples because it's so complicated. The idea that you're going to keep someone alive by pumping their heart and breathing for them, but the actual CPR is so simplified that people don't even have to really know why it works to have it work. The next slide, please. I already mentioned this. These are the behaviors that are often associated with reactive violence, and they are so staff limit setting, staff having an activity demand, like you got to do this, and staff denying a request. Now, we understand that this is the job of many staff people in the hospital. So the point is not that don't do this. The point is, how can we do this in a way that it would be less provocative and less likely to boil over that thermometer? Next slide, please. So here you can, is this a Menti? Is this a Mentimeter thing?
Tom, this is a poll.
Ah,
So I'm just going to activate it real quick.
All right. So the question is, which one do you think is most associated with violence? And this comes right from Len Bauer's massive, I'm going to take the poll too. Because I know the answer, so. My poll doesn't freaking work. Sorry.
So we're just going to let the poll go for about a minute, and you can vote, and then we'll share the results to see what people thought was the most associated with inpatient violence.
Nice. All right. And why don't you advance in the meantime? Because I know I've been blathering.
Okay.
So this slide, this is a bank. And it's one of the things we've been using in training is to conceptualize what we're trying to do as building a bank account with each person we work with. And it's not just during activity demands, denials of requests, and limit setting, but really all the time. Like we're building a good relationship. And I believe 3 steps to safety is a good way to do that bank account building. Next slide, please. So here are the 3 steps. They're really not that complicated. The acronym is VEP, validate, explain, problem solve. And next slide.
Before I go to the next slide, do you want to see the poll results?
I do want to see.
So I'm going to end the poll. We had about 74% participate, but here are the results.
That's so good. Yeah. That's kind of what I would think is most associated. According to Bauer's research, it was activity demands were the largest driver. I don't know why it would be an activity demand.
Well, the activity demands can be like, take your meds, get out of bed, go to group, do something you don't want to do.
I'm sure that is it. Yeah. Yeah. So anyway, then you learn. So at least that's what Bauer says. And who knows? He could be completely wrong. He could have made that up. Next slide, please. I want to make sure we leave enough time for the video. So the first step, validation, I've tried to simplify the definition, and it's complicated. Communicating that there is something true and important about someone and what they think, believe, or do. So validation, it's a broad idea. Those 2 heads on the left, I like this idea that if the counselor is on the left, the idea of validation is to look into the brain of the client, of the patient, and see the world through their eyes and identify what's true and meaningful and valuable about them and their perception. I think that's really terrific. Next slide, please. So Marcia Linehan, who talks a lot about validation and in many ways DBT, oops, I think we lost the slides. In many ways, DBT, dialectical behavioral therapy, one of the cornerstones is the idea of validation. And she identified 6 levels of validation. When I first did 3 steps to safety, I really went right to the 5th level, saying it's normal. In other words, oh, could you back up one slide? The 5th level, saying it's normal. So for example, could you go forward one slide? So for example, if somebody gets angry because they feel like somebody disrespected them, you could say something like, yeah, I get it. I'd feel the same way. Like that's a normal reaction. But the other levels, the first level, like paying attention, I've been in team meetings, and I don't have the experience you guys do by any means, but I've been in team meetings where a patient will come into the team room and the psychiatrist or somebody just won't look up, that they're busy writing or they're on their phone or they're doing whatever they're doing. And it's an example of the opposite of the validation. I'm not blaming that person. Everybody's super busy. All right, so that's the first level. Second level is reflective responding. You're probably pretty familiar with active listening and reflective responding, but the idea of communicating that you heard the person is a type of validation. Saying what hasn't been said. So like my wife is a therapist, and she'll say to young people who have had a very difficult traumatic experience, she'll say, that never should have happened to you. And which is obvious, right? But it's often very meaningful to the person because nobody ever said that necessarily. Connecting to past history or biology is something like, listen, based on where you come from, that's how you learn to react. And right. So, based on where you come from and what you've learned, your learning history makes perfect sense. And then I talked about number 5. Number 6, radical genuineness is the idea of, it's not tactical or anything. Maybe you give the person a hug and you shed a tear with them if they've lost a family member or something like that. It's being a real person. I mean, imagine that, being a real person. Next slide, please. So there's some limits to validation, and it took me a long time to understand what Linehan was talking about when she referred to this. But the example here is kind of a good example, I guess. The patient says, I have to kill him because he disrespected me. And what you don't want to do, you don't want to say, yeah, I'd kill him too. That makes perfect sense. But you imagine what you could validate here is like, yeah, listen, I'd be angry too. And if you try to hurt him, it's just going to hurt you, right? And he's not worth it. And you don't have to respond in that way. But listen, I get it. That was I understand what it feels like to be disrespected. So that's the idea of, you don't want to validate the unvalidatable. There are limits to validation. I will say one other limit to the bank account and maybe to validation is you also don't want to bribe the patient into liking you or having a good relationship. So you hear stories of staff bringing in sandwiches or gifts or something for the patient. And maybe in the short run, placating the patient is helpful, but it's absolutely a limit to the bank account is, you've got to stay within the reasonable boundaries and policies and procedures. Next slide, please. Okay, the second step of 3 steps to safety, and we practice this when we train it, and we hope to see it in supervision where we practice. But the second step is, if you're engaged in limit setting, activity demands, and denials of requests, to point out this is not personal, and what is the reason, right? That we're not out to get you, for example. It's hospital policy. So I won't belabor this, but a bit more to it, but that's the basic idea. That's the second step. Next slide, please. The third step, the P of VEP, the VEP P, is how can we help the person get what they would like to get, if that's possible, or what can you do if in the face of not being able to get it, or to being required to do something, or being limit set, or having a request denied. So if possible, like if you get your level up, or one one thing I remember one of the complex administrators here in New Jersey saying is, yeah, we got to help you get out of the hospital because the hospital will always have those restrictions, right? It's, you know, it's what sucks about being in the hospital. A lot of things suck, but that was one of them. All right, so those are the three steps of 3 steps to safety. And you can try to remember them by saying VEP. And our early research is that when people use these, they really can develop a better therapeutic relationship. And we hope that I hope that it's simple enough to be like CPR, where it can help prevent violence, and that it's the thing we hope people use it all the time. So like validate, explain, and problem solve all the time, not just during around activity demands, denials of requests, limit setting. Okay, so let's, and I apologize for going so quickly, but wanted to get to this video. We're gonna watch a video now, and you'll have the opportunity to rate the video. And what we want you to look for, particularly, is the staff person, the guy on the couch, validating, explaining, and problem solve. And I think we're going to focus just on validation for right now. So let's watch the video. Uh-oh, do we have a volume? Yeah, I think we're missing volume. I could dub it.
You can't hear that?
I cannot hear it.
Okay, hold on.
I seem to remember that was a glitch we've had in the past.
I gotcha. Sorry about that.
Man, it's 2 a.m. There ain't no phone calls this time of night. Yeah, but it's very important, man. 2 a.m. No phone calls. I'm a grown damn man. You on your phone all night. Man, you're gonna have to stop worrying about what staff do and worry about what patients are supposed to do. It's 2 a.m., man. Go ahead, take it back.
This guy go again, man. Every night is something new with you, man. What's going with you now? Every night is something new.
Holy jeez. Oh my God. Oh. Woo. Yowza. All right. Well, I was there. I was kind of a bystander, and Phil is a big guy and very powerful. And thank God he kind of tossed the chair to the other guy, because he could have squished him. All right. So the question is, did you see validation? And if you did, what would it have been? And when we rate 3 steps to safety, we have these behavioral anchors, and we ask people to learn 3 steps by rating other people doing it or trying to do it. So what do you think? Is it staff was invalidating, staff ignored the patient, was mean, or told them they should not think or feel the way they do? Or was staff kind, but no further validation, or ORS was used? ORS is open-ended question, affirmation, reflection, and summarization comes from motivational interviewing. Or 3, staff used and or validated the patient. What do you guys think? Clearly, it didn't go well, right? All right, so let's fill that poll out. How are we doing for time, Dawn?
You have 12 minutes.
All right.
So it looks like 98% of responders chose the first response.
Clearly, that was too easy, because yes, you're correct. All right, let's watch the second video. We have a whole bunch of these. So these are obviously training videos. So I get to see these all the time, and they crack me up.
Hey, Tom, you open the door, man? I got this phone. Hey, what's up, Eugene? It's 2 o'clock in the morning, bro. You know when the calls at the time. Damn it, man. Use the phone. Oh, I can see you upset, but what's going on?
I got family issues.
Oh, you got problems with the family?
Yes, I had to call my uncle, man. My mom is sick in the hospital.
Your mom's sick in the hospital. I can see that's upsetting you, but it's it's still after 10 o'clock. There's not much we can do about that tonight. I mean, I know that's messed up.
Hey, Tom, what's going on? I see Gene is upset.
Hey, what's up, Phil? Yeah, I was talking to Gene. His mom's in the hospital, and it's apparently he was trying to call his uncle to get some information. I'm assuming. I was telling him it's not much we about that because it's after 10 o'clock, but definitely can help him out in the morning with it.
Yeah, I'm sorry the way you feel about that, but that's something we can't really do right, tonight. But tomorrow morning, I think first thing tomorrow morning, we'll have first shift come in, have you meet with the social worker, call your family to see if you can resolve this issue, see if you can get some relief from this issue.
Man, this fucking place sucks, man.
I'm sorry you feel that way.
Yeah.
G.
Fuck, God, get the fuck. All right. That bullshit, That's messed up.
All right, let's try the we're just ranking validation. See how he did that time.
Sorry.
That's okay. Okay, so again, with staff invalidating, staff ignored the patient, was mean. Or number 2, staff was kind, but no further validation, or ORS was used. Or 3, staff used ORS and or validated the patient. I actually noticed my head bobbing back and forth in there. So I can take some credit for these wonderful videos, even though it was all Eugene Colvin. All right, go ahead and fill out the poll.
Okay, so we have a little bit of a mixed result on this one.
Yep.
So most people said staff used ORS and or validated the patients, but 18% said that it was like staff was kind, but no further validation or ORS was actually used.
Yeah, and this brings up a really good point about the way we think about think about 3 steps and the training and the videos. Is the point is, it's not as though there has to be an absolute right answer. The point is we get better and better at identifying validation and using validation. Yeah, I thought that one area where he validated, he said, yeah, that's messed up, right? And if you remember the definition, there's something real and important about what the person is saying. So that was something I took away. But listen, I respect, we can see it differently, and that's fine.
Can I just add one part to that, Tom?
Yep.
I know in some of the presentations where I've used this video, people say, well, he didn't get his problem solved, or he was still really pissed off and he still threw a chair, or he still, kicked the can and he still cursed. But so, yeah, that's all true, but no one got hurt, right? So when we're looking at trying to de-escalate and prevent violence, there's not going to be one sentence that's going to bring out all the unicorns and rainbows. People can still be upset and legitimately so, right? He had a valid reason for being upset, but he was still angry, and that's okay. He wasn't punching people. He wasn't diving at people. He wasn't lunging. He walked away and he kicked the can and he went away. And that's a much better outcome. So was it perfect? No, you're not always going to have the perfect outcome, but no one got hurt.
Yeah, it's such a good point. And one of the things that I've learned is that staff in these stressful, whoop, here he comes again.
Hey, Tom, you open.
Goodness.
That staff in these stressful situations also have an effect on their ability to think and so we want to do the best we can. And it's easy to, in retrospect, to criticize staff, but when you're in it, it can be very difficult. Yeah, so you make such a good point, Jennifer, that it oftentimes when you have a good relationship with patients, it just improves the situation, but it doesn't solve the problem. Like, he still wants to use the phone and he's still pissed off and he could still be violent. But what we're doing is we're turning down the flame, and we're hopefully not contributing additional heat to that thermometer going forward. So that's what I have for you today. And I recognize I talk really fast and I'm a bit nerdy, but any thoughts on 3 steps to safety? I understand we have some people from Texas and elsewhere. Welcome. And hopefully you got something out of this. And we may want to do additional presentations on violence prevention because it seems to be popular.
But we do have about 6 minutes left. If anyone has any questions that they'd like to throw in the chat box. As Dawn put in the chat that the link to the training evaluation is available. It will also be available as soon as the webinar stops. And at the training evaluation, you'll have the copy of the handouts, a certificate of attendance, a link to the TED Talk, and
oh, Jennifer, if they reach out to us, we can send them the manual on 3 steps to safety if they're interested. Oh, I'm seeing a lot of that. More presentations on inpatient violence would be appreciated. So that's good.
And if you have to leave right after the presentation, you'll get an email. Anyone who attended today will get an email tomorrow with the training evaluation link.
How can they request the manual?
So when we send out the training evaluation link and the follow-up email tomorrow, you can just respond to that and we'll get that from you. It'll come from Rutgers Spree, the email, just as the registration information did. So when you get that in the morning, you can respond back to that and say, please send me the manual, and we'll be happy to do that.
Can we add a Venmo link where they give me $1 for every copy of the manual? No, it's not good. I can tell by the laugh that's not going to happen.
Not happening.
It's all right.
So this link to the TED Talk is linked in the training evaluation. The training evaluation link, Karen, will last as long until you get your email. It doesn't expire.
That's a soupy sales move. That's awesome.
References.
I should probably read those references, Jennifer. You want to go back to that?
I think no. I'm going to just move on to this.
Hey, just seriously though, that Bartholomew reference, #2, that's my dissertation. And granted, it will put you to sleep, but there's also a ginormous number of references available on inpatient violence if you're interested. And if you're having trouble sleeping, you want that. Maybe I'll end on this note about we've been using 3 steps to safety in New Jersey, and I know now in Washington State they're using it. In Virginia they're beginning to use it, and in Michigan they're about to start using it. And I think my team and I are convinced that it's not that hard to know what would be better for state hospitals. It's hard to change state hospitals to do what would be better. And that's our focus going forward, which is how do you do implementation in a way where people are open to it and there's enough readiness to make it work.
All right. Well, I want to thank everybody for joining us today. Our next prep webinar will be on December. I'm just pulling up my calendar. December 19th. As always, it's the 3rd Tuesday of the month at 3 p.m. Eastern time. And keep an eye out for registration information and look for the follow-up email tomorrow. And please respond back to it if you would like further information on the 3 steps manual. And also, I will include a link, as Dawn mentioned in the chat, that the recording of this webinar will be available on our website, as all of them are. So if you've missed one in the past that you want to go back and revisit, or you didn't get a chance to attend live, they're all archived on our website. So all the recordings of any webinar that we've done since November of 2021 are available for you. So thank you all so much for coming. Have a wonderful Thanksgiving, and we'll see you next month. Take care.